Good afternoon. My name is John Johnson. I'm a chest physician. I've been working with the TB research unit for about 20 years, mainly with trials for prevention and treatment of TB. I'm going to talk about what's been a hot topic over that past year, and I'm sure that anybody following the wire services knows a lot about the international traveler with drug-resistant TB. I'll update you a little bit about that. Although reported case rates in the United States for tuberculosis are as low as they've ever been in recorded history, TB is a major worldwide health problem, particularly in HIV-affected individuals. Worldwide, there are about 10 million new cases a year and about 3 million deaths. 98% of those deaths and 95% of all those cases occur in developing countries, particularly 20 heavily hit countries, mainly in sub-Saharan Africa and Asia. Because TB is a respiratory pathogen, and it's true though that TB anywhere is potentially TB everywhere. And we live in a world where people get on airplanes and move around, and there's more in and out migration than any other time in human history. Drug-resistant forms of tuberculosis largely represent failure in application and follow-through in TB care, and that'll be one of my main themes today. There have been sporadic cases of drug-resistant tuberculosis reported in many countries over the years, but they've been very small in number. They've usually been in individuals who've been non-compliant with their therapy, had social, alcohol, drug abuse problems, and they've been in small numbers. But in September 2006, at the time of the International AIDS Conference in Toronto, for the very first time, we had a major outbreak of what was termed extensively drug-resistant tuberculosis that occurred in South Africa. And these are some of the headlines from the local papers there, and they're fairly serious. Killer TB tightens fatal grip, government's hands tied, and I'll give you a little bit of the background of this epidemic in a few minutes. In the US this past summer, if you watched CNN or any of the newspapers, there was a lot of attention about this case where this pretty atypical looking tuberculosis patient, at least from the public conception, a 27-year-old attorney from Atlanta, got on an Air France commercial flight with about 440 patients on it and flew to Europe and came back into the United States where, for the first time since 1963, the CDC actually enacted a federal isolation and quarantine order on the individual. Subsequent testing has established that he actually has it a little bit easier to treat multi-drug resistant TB than extensively drug-resistant TB, and he's being cared for by the treatment unit in Denver and doing fairly well. But this caused a major outbreak, and he's, despite the way he looks, he's certainly not the guy you'd hoped you'd spend 7 hours on a plane next to. My learning objectives here today are that treatment of extensively drug-resistant and MDR-TB is a specialist area, but I want to give you an overview about the epidemiology of this. I want to talk about how drug resistance in TB evolves as a result of poor TB control, talk a little bit about the challenge of treating it and the implications that this has for global TB control. This chest x-ray from a patient, non-HIV infected patient with typical tuberculosis. TB is characterized, it's a necrotizing pneumonia, meaning that it actually destroys lung tissue and produces cavities like you see in the right upper lung field of this patient. Typically involves the upper lobes of the lung. In patients with active cavitary tuberculosis, when they cough or speak or sing, cough out particles that generate infectious droplet nuclei that are inhaled by non-infected persons and are the nidus for the spread of tuberculosis. Transmission of TB is largely about shared air. TB is contagious, but not terribly so. It is a respiratory pathogen. The infectious dose for man is low, but it is difficult to transmit TB by very low-level casual contact. It occurs rarely in highly infectious individuals, but generally it's about shared air, and people who live in the same home, people who work in the same congregate area, people in prison settings and that are most likely to be repetitively exposed and acquire infection with TB. Once the tubercle bacillus impacts and gets through the upper airway defenses, it can establish a nidus of infection in the lung and the regional lymph nodes. Most of us, immunocompetent hosts, cure the infection, all right, and the only sequela of that event is marked by a positive tuberculin skin test 4 to 6 weeks later. Only 5 to 10% of immunocompetent adults, adolescents, will develop tuberculosis over the course of their lifetime. So most of us are actually able to deal with this and don't develop active tuberculosis. Immunosuppressed individuals, people with rheumatoid arthritis, being treated with TNF inhibitors like infliximab, HIV-infected individuals, the situation is much different. Up to 8 to 10% of HIV-infected individuals with a positive tuberculin skin test will develop TB every year. So that if you survive 5 or 7 years with your HIV, your likelihood of breaking down with tuberculosis is roughly 40 to 50%. So this results in enormous attack rates. In the world as a whole, and this is all cases of TB, not the situation with drug-resistant forms. Now, the general gist of this slide, which is based on the most recent WHO data, is the darker colors are those that are most affected, and the greatest burden of tuberculosis is in the developing world. And hard-hit areas particularly have been sub-Saharan Africa, Asia, countries in the former Soviet Union. Rates are actually very low in Oceania, North America, Canada, Scandinavia, some areas of Europe. But former Soviet Union been hit. And because largely the concentration of the population mass, 1/2 of all the cases of tuberculosis in the world right now are in the Indian subcontinent. This shows the interaction of TB and HIV. In the United States, about 8 to 10% of newly diagnosed individuals with TB who get tested, not everyone does, are HIV co-infected. That's up to 50 to 70% in areas of sub-Saharan Africa, and explains a tremendous global burden of TB and the catastrophic situation that's resulted in parts of sub-Saharan Africa. This shows that US data. We have data since the late 50s, and what was happening between 1950 and 1988 was we were seeing about a 5 to 7% overall gradual decline in TB cases in the US in the modern chemotherapy era. What does Congress do when the disease's incidence rates are going down? They pull the funding. They pulled the block grants to the TB control programs, and this and the interaction of the HIV epidemic would probably do at least as much to the dismantling of TB control in the US as anything, resulted in a spike. And there's an excess of about 28,000, 30,000 cases that occurred under this curve here until people put the system back together again, supervised the patient's treatments, and the problem went away. Right now we have overall rates that are less than 6% for the United States. It's the lowest we've ever had, and I think this is a tribute largely to just good fundamentals of TB control. The epidemiology in the United States, though, it's spotty. Ohio here is a gray state. Our rates are less than 3.5 per 100,000 population per year. That amounts to about 225 cases a year, and about 1/3 of those occur in Cuyahoga County, the other 1/3 around Columbus, Cincinnati, and with the remainder kind of scattered around the states. The heavily affected states are the border states, New York, New Jersey, coastal states, Florida, Texas along the Mexican border, and California. And the most important long-term epidemiologic trend in the United States is that in 2001, for the very first time, that we have surveillance data, the number of cases, new cases in persons who were born outside of the United States exceeded those of persons born in the US. Okay, so TB in the US now has become more of a disease of foreign-born individuals. There's an excess of cases in minority persons as well. Worldwide, for simple drug-susceptible pulmonary tuberculosis, standard short-course chemotherapy is given for 6 months. And these are drugs that we've had for many years. Initial intensive phase of treatment when the numbers of tubercle bacilli in the lung are very high, INH, rifampin, ethambutol, pyrazinamide, followed by 4 months of INH and rifampin. This is highly effective. Through WHO initiatives, you can buy a full treatment course of high-quality drugs to treat a patient for tuberculosis for about $18. So the cost of providing drugs to treat the disease is not the barrier that it once was. Having said that, 6 months is a long time. We call that short course therapy. If you had to be treated for pneumonia for 6 months, you'd be complaining to your doctor. So patients typically begin to feel better after 3 or 4 weeks of treatment, and this is a time when they want to go back to work and they've got other things better to do than to finish completing their TB treatment. How effective is this for drug-susceptible TB? If you fully supervise it and patients take their drugs, you can cure 95 to 98% of all people with tuberculosis of this and get a durable, long-lasting cure. There are some minor side effects. It's too long, and that's a major obstacle, but it is highly effective treatment if it's fully administered. For the talk today, I need to define 2 terms briefly so we understand what we're talking about. The term MDR-TB is multi-drug resistant tuberculosis, and this means tuberculosis that's resistant to at least isoniazid and rifampin. And this is important because INH and rifampin, particularly rifampin, which is our most bactericidal drug against tuberculosis, are the cornerstones of modern TB chemotherapy. Once we lose susceptibility to rifampin, then we lose all possibility of treating the patient for durations of time less than 1.5 years and 2 years. So it has a very pivotal role. Extensively drug-resistant tuberculosis is MDR+, okay? Patients who have resistance to INH and rifampin, plus a fluoroquinolone, which have been helpful because they can be given orally, and at least one of the 3 injectable drugs. So we're talking about we've already knocked out at least 4 of the 6 major classes of anti-TB drugs. I will review the biological basis of how bad TB treatment and poor TB treatment makes the resistance problem worse. But first I want to say that really this drug-resistant TB, MDR-TB and XDR-TB, is largely a man-made problem. It's a problem with the application of TB control. We have good drugs. We don't have as many alternatives as we'd like, but we have a means to cure most patients with tuberculosis in the world today. We just haven't had the commitment and the resources and the organization to do it. Drug-resistant TB occurs when patients don't complete their full course of therapy. This is very common, particularly in many developing countries. When physicians prescribe the wrong drugs, the wrong dose, the wrong length of time, the wrong regimen, and this is surprisingly common, not so much in national TB control programs, but in TB that starts out being treated in the private sector in many areas of the world. When drug supplies are unreliable, when the national program runs out of rifampin for 2 months and patients are just given isoniazid alone, sets up a bad situation. How bad is drug-resistant TB in the world as we stand? The WHO estimates, and these are just estimates, that we probably have about 400,000, a little less than 500,000 cases in the world, about 4% overall. So the problem is not critical yet. Most patients have drug-susceptible TB, but we'll talk about how this spreads. Most of the burden of disease is concentrated in China, India, and the former Soviet Union, where TB control practices were very sporadic. We know a lot less about the prevalence of XDR-TB. I'll show you in a few minutes what we do know. This is another projection of a world map just to show the problem. This is MDR among new TB cases. Right? This is important because these are people who have not previously had TB drugs been treated. So what this represents is people who are becoming infected de novo with drug-resistant forms of tuberculosis, and represents a failure of the TB control program in the past. And these are highest in areas of the former Soviet Union. Not such a problem in most of the rest of the world. The situation is much worse in people who have been previously inadequately treated, with attack rates of over 40% in some parts of the former Soviet Union. These are people who've been treated, they've seen drugs, usually intermittently, usually sporadically, and they've gone on to evolve and accrue drug-resistant TB. In the United States, we had an excess of cases of MDR-TB during that earlier outbreak in the early 90s. If you look at the absolute numbers, we had more MDR than we do now. Right now, it's about 1% of our TB caseload in the United States. Most of these cases now occur in foreign-born individuals, and they represent failure of adequate treatment of tuberculosis in coastal and bordering areas. Many of the patients with MDR-TB originate from the Philippines, from China, from Mexico. Those are among some of the major countries where these cases have emerged in the United States. In Cuyahoga County here, where we have a very good TB control program, we've had some of the lowest indigenous drug resistance rates over the last 40 years. We have very little. We've had no new endemic cases over the past 4 years. We had one patient from Korea with MDR who was successfully treated and cured here, and there are no active cases in the county program. In 2006, for the very first time, though, we had a major outbreak of extensively drug-resistant tuberculosis, TB-resistant to INH, rifampicin, and basically all of the second-line drugs that were available in South Africa. This outbreak occurred on the Eastern Cape, KwaZulu-Natal province, which is an area that's been heavily hit by the HIV epidemic over the past 10 years. This is a picture from the area itself from one of my colleagues at WHO. It occurred in Tugela Ferry, which is actually a very rural area. But there's quite a bit of migration in and out here. Farmers, other people go to the cities to work in the mines, and then there's migration back and forth. There was a high rate of attack rate of HIV, and the hospital there, the district hospital, began a program to roll out access to antiretroviral therapy. And when people were being HIV tested and evaluated for antiretroviral therapy, they underwent chest x-ray and sputum exams for TB, and many of them were found to have active TB, and they were treated. Well, over the next 6 to 8 months, what they noticed there was that patients, when they measured their viral loads for HIV, was that they were becoming undetectable, but they were still actively coughing and seemed not to be responding to anti-TB treatment. And that's what really led to the recognition of this outbreak, was just excess deaths occurring in people who were adequately treated for HIV but were failing treatment for tuberculosis. And they had access to culture and drug susceptibility testing down in Durban, and 53 patients, 1 out of 10 there, were identified as having extensively drug-resistant tuberculosis. 40 of those patients underwent HIV testing at some point in their care. All were HIV co-infected. Mortality was incredible, and 52 out of the 53 patients identified died within less than a month. 6 of those were healthcare workers, also HIV co-infected. The characteristics of the people who developed extremely drug-resistant TB and died in that epidemic, it's important. 51% of them had no prior treatment. So these represent individuals who probably, when they were infected with TB for the very first time, inhaled, were exposed to, were infected with a highly drug-resistant form of tuberculosis. 2/3 of them had been hospitalized previously within the previous 2 years, all at the district hospital, and all of them got care at the local clinic. There was some contact investigation done in the community, and the conclusion of all this is that much of this probably represented transmission of highly resistant tuberculosis occurring in clinics and hospitals in the nosocomial setting. 85% of patients had an isolate that could be fingerprinted. Most of these were actually not Beijing strains or other strains that have been implicated in MDR outbreaks, but they were just the KwaZulu-Natal strains that had been identified and tracked in the area for the previous 10 years that patients had become resistant to. To date, and this is data through May of this year from the WHO, there are 45 countries in the world that have reported at least one case of extensively resistant tuberculosis, and they're scattered throughout. There is very limited systematic testing for susceptibility to second-line drugs throughout the world. The WHO runs 14 supranational labs in various regions, and a little bit of work has been done. And they were able to pull together results from what's really a small number in terms of the overall cases, but about 18,000. And overall, 20% of those were MDR, and 2% of these, of the MDR isolates, were actually XDR. There's a little bit of country-specific data. In the US, it's about 4%. Areas like Latvia, former Soviet Union, and Korea, 15 and 19% of the MDR isolates were actually XDR, indicating that these are in a more advanced form of the epidemic. What about the US? This is data on XDR for the last 14 years. And we have pretty good information because all the state labs send their isolates to the CDC anymore. And there are 42 cases been reported over the last years. New York, New Jersey, California are the big losers in this survey with the most cases of XDR. Who gets XDR in the United States? Some of the MDR in the 90 were actually XDR. The numbers are small now, less than 4 a year. But 75% of these cases now are occurring in individuals born outside the United States. And that's really where the XDR problem is in this country now, and a few other sporadic cases, less than 4 a year. How do you get from drug-susceptible TB to XDR? Very difficult or impossible to treat tuberculosis. We've known about drug resistance in TB for a long time. This is data from Thorax from 1950. This reports sputum counts in patients who were being treated with streptomycin alone, because that's the only drug we had that was active against tuberculosis at that time. These are the numbers of organisms in the sputum on quantitative culture. This is sensitivity to streptomycin compared to a wild-type strain. And this is days on treatment. And the patients clinically and bacteriologically did very well during the first month or two. You know, things were getting better. But if you look at time, there was this what's now classic fall and then a rise as drug-resistant forms of tuberculosis begin to emerge. And the patients clinically began to fail treatment. What happened then? People waited until we had the next TB drug out, and then they gave that to everybody, and the same thing happened all over again. It wasn't until the late 1950s that Sir John Crofton and the group at Edinburgh finally decided the best way to treat people with TB was to give them all the drugs at one time. And this really was the invention of combination chemotherapy and really allowed us to cure patients with TB. But acquired drug resistance during TB treatment is not a newly recognized phenomenon. We know from the very beginning that this happens when patients are treated with single drugs. The biological basis to this is that if you look at wild-type MTB, and people who have never seen an anti-TB drug in Antarctica, okay, there are very small numbers of organisms that are present within the bacterial population that are resistant to the anti-TB drugs. And this ranges from 1 in a million to 1 in 100 million organisms, but it's a naturally occurring phenomenon. These are due to spontaneous chromosomal mutations that affect key proteins, enzymes, and energy metabolism. Unlike resistant gram-positive organisms, resistant gram-negative organisms, there aren't transposable multi-drug resistant elements that can be transmitted from bacteria to bacteria. So people develop MDR-TB and XDR-TB through the acquisition of sequential chromosomal mutations. If we know that small numbers of organisms are resistant to single drugs, and we know from doing quantitative cultures of sputum that a patient with a tuberculous cavity has more than 10 to the 8th tubercle bacilli in their lungs, if we give the patient 2 drugs, we know that the chance that any TB organisms in that patient are resistant to both of those drugs is actually equal to the product of their individual resistance. It's a little bit simplistic, but the concept's important. So if we give the patient isoniazid and rifampin, then the chance that the patient has any tubercle bacilli when he starts treatment that are resistant to both is in the range of about 10 to 14 and should theoretically exceed the load that's present in the patient. It is a fundamental principle of combination chemotherapy for TB, and it's also analogous to treatment of diseases like HIV and others. A little more schematically, if you look, a patient with untreated, developing active tuberculosis, the organisms of tubercle bacilli continue to divide, and in this enlarging population of organisms, there are very small numbers of organisms that are resistant to each of these drugs individually. That gets to be a large population. If you treat a patient like that, you don't recognize he has active TB and you give him isoniazid preventive therapy alone, you kill everything in here. You kill the R and the P resistant and all the susceptibles, but there still are small numbers of isoniazid resistant organisms in there that can multiply. Whereas if you treat the patient properly with combination chemotherapy, you can eliminate all that small number of drug-resistant organisms at the same time and cure the patient. If you take that patient who's been exposed to isoniazid and is outgrowing INH-resistant organisms, and you just add one more drug at a time, like rifampin, what happens? At this time, there are a small number of bacilli out of this larger population that are spontaneously developing resistance to rifampicin. They outgrow, add another drug. Sequential drug resistance evolves, and you basically end up with a form of tuberculosis, very difficult or impossible to treat. So when we're trying to identify patients and programs, who's at risk for MDR-TB? If a new patient comes in, how can you identify? The most important things to ask are about previous TB treatment. You may not be able to get all the particulars, but have they ever been diagnosed or treated for tuberculosis? And then try to find out with what and any previous information you have on them. People who have origin from areas with high rates of MDR-TB are also people that you have to be cognizant of at the beginning, or a patient who's lived with been a household or work contact of an MDR case. In combination chemotherapy for TB, our goals really are to try to provide safe, effective therapy in the shortest duration of time. As I've shown you, we try to give multiple drugs to which we have good reason to believe the patient's likely to be susceptible. We need to be sure the patient takes that treatment, and we need to avoid adding single agents to patients who are clinically failing treatment because we just make the problem worse. We all have patients with hypertension and other things. In TB, we've kind of given up on human nature and just accepted that nobody, including a physician with TB, can adequately be trusted to take medication every day for 6 months, particularly when they're feeling better. So the global standard for treatment has become based on supervised, or what's colloquially called DOTS, directly observed therapy, and that includes where programs. Some of it's done in clinics, like this one in Johannesburg, where a patient comes into the clinic once a day. Healthcare worker watches him swallow his medicines, gets nutritional supplement. And importantly, it's not just about swallowing the drugs. The supervisor, whether it's in a clinic or whether it's in a community, and some of the supervisors are family members, some of them are ministers, some of them are outreach nurses, some of them are bartenders, to serve as a supervisor to help the patient complete their treatment and get cured. And this is highly effective, and it's also actually been shown in many settings to be highly cost effective to cure the patient. This has led to the WHO's recommendation. We have a global standard for the treatment of tuberculosis called DOTS, directly observed therapy short course. And part of it's about watching patients take their drugs in supervision. But in addition, you need a country that's committed to its TB program. You need to have diagnostic services, a pharmacy chain intact so that you've got essential drugs, and you need a reporting system so you know how many cases there are now, and 2 years from now, and 5 years from now, and so you can see whether or not you're actually curing the patients that you're treating. Important thing here is this has taken the emphasis off the patient as being the only one who's supposed to come back and be sure he gets cured of his tuberculosis, to a multi-level responsibility where the national program and the local TB control program and the doctors and the patient through the program share responsibility for curing the patient of tuberculosis. This is a stained sputum smear for AFB microscopy. This was described in 1888. It's the most common diagnostic test in the world for tuberculosis. Patient coughs into a container. The sputum is then spun down and concentrated, and it's stained, and the tubercle bacilli retain this very deep red carbofuchsin stain and appear as quotes, acid-fast bacilli. One of the problems with this is if you don't get a culture, you don't get an organism that grows out that you can do drug susceptibility testing. So this is a limitation in terms of trying to identify and track drug-resistant TB in the world. Most countries depend on this. Some countries in sub-Saharan Africa only have 2 labs that can do culture and 1 lab that can do drug susceptibility testing in very high TB burden areas. Fortunately, the WHO, and similar to malaria, TB has been the attention of a lot of money from Gates and attention from the NIH because they recognize that people are mobile in the world. And we do have developed rapid rifampicin drug susceptibility testing assays that can give us information about that key drug within a very short period of time. There are new culture systems that are simpler that you can roll out in developing country settings. Some of these are actually in early clinical use, and there's a lot of work going on by many groups in the world to improve the situation. But right now, one of the problems is that we're still using a 100-year-old test. We'll turn now to the few principles about the treatment of MDR-TB. MDR is very difficult to treat. It's not something that should be taken on by the average hospital, average practitioner. It's a specialist problem in terms of drugs and the toxicity. One of the biggest problems is that you need to treat patients for 18 to 24 months after they've converted their sputum cultures initially to get durable cure in patients with MDR-TB. It's costly. Probably costs around $50,000 for the drugs for a not terribly resistant form of TB, and maybe $500,000 to try to treat an XDR-TB case. These drugs have a lot of gastrointestinal and neuropsychiatric side effects, and they're difficult to get patients through, particularly middle-aged and elderly individuals. All treatment for MDR-TB should be daily, and it should be heavily supervised. And even with that, we can probably, under optimal circumstances, cure about 50 to 70% of people with tuberculosis. Some of the others will die. Some of the others, unfortunately, have long-standing open cavitary disease, and they can represent a significant transmission problem in the community. And that's where those people who walk in with XDR-TB and have never seen a TB drug before happen. They're infected by somebody who's out there coughing and has chronic, open, drug-resistant tuberculosis. In TB, we generally divide our drugs into first-line drugs, and these are old. The last of them, rifampicin, was introduced in 1968, so we haven't had new drugs for a long time. And then second-line drugs. Injectables, old familiars like streptomycin, kanamycin, been around for a long time. And then oral agents like ethionamide, which is difficult, has a lot of gastrointestinal toxicity. Cycloserine, which is kind of nicknamed psychoserine because of the neuropsychiatric side effects, and the modern fluoroquinolones. What's involved in treating a patient with MDR-TB? The general principles are that when you have some knowledge about the likely susceptibilities is that you use any of the first-line drugs that you still have susceptibility to. If you're lucky, you'll have pyrazinamide and ethambutol left. Then we pick one of the injectable drugs, streptomycin, kanamycin, capryomycin. We use an oral fluoroquinolone, and then we try and hope we can pull out enough drugs that the patient can tolerate from this last classes of drugs, PAS, cycloserine, and other agents, to try to get to 4 to 5 active drugs in the regimen. If you have less than this, you're likely to acquire more drug resistance, as we said before, and the outlook isn't good. If we can get 4 to 5 drugs in the regimen that the patient still has activity to, then we can hope to try to achieve a cure rate of about 70%. The WHO finally acknowledged the seriousness of the MDR problem, and in 2000 they rolled out the DOTS Plus strategy. And the idea here was they had a cleverly named Green Light Committee, which was a committee that sat and national TB programs applied to the Green Light Committee. And one of the stipulations before you got access to second-line drugs, subsidized through the Global Drug Facility, was that you had to have provided evidence over several years that you were actually doing a good job in your country with DOTS and treating the garden variety routine forms of tuberculosis in the country. Depending on local resources and labs, there was an individualized treatment approach, and where that wasn't possible, trying to design regimens that, based on what information you had, would be likely to be active in the patients. And many of these projects, demonstration projects, have actually reported cure rates for MDR-TB that are as good as any that have ever been obtained in the United States. So DOTS Plus works, but unfortunately the number of centers and places that can implement this are limited. And one of the things that likely happened in South Africa driving the development of extensively drug-resistant there is that anytime you begin to treat TB, many areas of the world, there's some care that begins in the private sector, often by people who are less informed, using one drug, two drugs at a time. And this has amplified the drug resistance problem. But for XDR-TB, the situation in treating patients is pretty grim. And this shows the MDR sequence plus what you have to do with XDR. So by definition, you've lost INH and rifampicin. So you hope you have pyrazinamide or thiambatol left. If you have XDR-TB by definition, you can't use a fluoroquinolone, another good oral drug. Can't use an injectable agent. Those are out. So what you're really left with is hoping that you have a bactericidal first-line drug left. Use any of the traditional oral second-line drugs. And then literally we're down to the point of using any drug that anybody has reported in vitro or human data on that has activity against tuberculosis. This is not very evidence-based, and it's very limited. It has been claimed without a lot of data that you can still cure 30 to 40% of HIV-negative patients with XDR-TB. But it's going to be difficult. You've got to put them in some place where they're not going to infect other individuals. And you've got to treat them for a very long period of time with very difficult to take drugs. And as I showed you in the Tuberculosis outbreak in South Africa, that XDR-TB is rapidly fatal in those individuals. Even if you can diagnose their drug resistance quickly and get them on treatment for TB and HIV, we may not actually have time for that to be effective. And XDR-TB in patients like the Tuberculosis outbreak may essentially be untreatable. Gates and NIH have kicked in for TB drug development in the last few years. Here at Case, through NIH and the CDC, we're involved with some testing of fluoroquinolones. This is phase 2 and phase 3 testing in drug-susceptible TB. And by definition, because XDR is resistant to fluoroquinolones, this is not going to have any impact on the XDR problem. There are a number of other agents, some of them that are very exciting, like TMC-207, which actually blocks ATP synthase in mycobacteria. A highly bactericidal, novel mechanism of action are beginning to undergo treatment studies in MDR-TB. But treatment for TB is combination chemotherapy, and it's going to be many years before we have new combinations of established approved drugs for the treatment of drug-resistant TB. Just licensing one more brand new drug, and giving it to everybody with MDR, XDR-TB, as I've showed you before, it may just lead to more development of more resistance to that drug. A couple of things that come up in the community about MDR and XDR strains. There was some old work in the 40s and 50s that showed that INH-resistant organisms maybe were a little bit wimpy. They weren't as fit as drug-susceptible TB organisms. But this has been looked at a lot more pragmatically in the past 15 or 20 years. And the data I show you is not based so much on molecular mechanisms of action, but epidemiologic. Because patients with MDR don't get diagnosed quickly, They are often smear positive. They're out there, they're coughing, they have contacts for a long period of time. This is one study that the TBRU here did in Brazil, which is an area with a lot of tuberculosis transmission. And we went out and skin tested contacts of patients with drug-susceptible TB and contacts of MDR cases in a prospective manner. The tuberculin skin test reactivity rates are identical. Okay, there's no difference. And there are several other studies from Europe, the Dominican Republic, that have found similar findings. So while you can demonstrate subtle differences in the fitness of the organism in some laboratory models, from a TB control standpoint, pragmatically, MDR and XDR strains of tuberculosis should be considered to be at least as infectious as drug-susceptible TB. If you get infected with a drug-resistant strain, are you any more or less likely to progress to active TB infection? In this study, identical. 4% of the contacts of persons in both groups developed active tuberculosis. So, in TB control, do you need to worry about identification and treatment of the drug-resistant cases? You sure do, because they're out there infecting other people and generating secondary cases. What about isolation? Here in the United States, we have negative pressure rooms, we have personal protective N95 respiratory masks. We can refer patients with resistant forms of TB to our regional centers of excellence. Most of the places affected by that MDR and XDR outbreak have limited access to any of these infection control procedures. If someone is infected or has contact with a patient with resistant tuberculosis and develops a positive skin test, is there anything that you can do to decrease the likelihood that that person will develop drug-resistant TB? If you have drug-susceptible TB, your contacts, we give you 9 months of isoniazid, which will prevent about 70–80% of the secondary cases. For MDR-TB, we recommend a fluoroquinolone plus pyrazinamide or thiamidol. There's a fair amount of GI upset with this, and it's been difficult. Completion rates are low. We don't really know from controlled clinical trials how effective it is, but I will say that there's one good study from South Africa looking at pediatric contacts of MDR cases that does suggest that this will prevent some secondary cases, so it is an option. But it's certainly not, highly evidence-based preventive therapy. Vaccine, it would be ideal if we had a vaccine that we could give to contacts of patients with MDR and XDR-TB or use them in areas to prevent secondary cases. If the drugs don't work, need to work on the immune system. Unfortunately, current BCG vaccines have limited impact in preventing tuberculosis in adults. There are 4 new vaccines in phase 1 testing, but it's going to take 10 or 15 years to do the phase 2 and phase 3 work on these vaccines, and I don't think we should depend on having a vaccine to help us deal with the MDR-XDR problem in the near future. Right now, we recommend that contacts of people with highly resistant forms of TB be skin tested, have serial observation, but and we may or may not give them this type of preventive therapy. Want to sum up, this is a map from IOM, just showing some of the major population fluxes in the world. You can see a lot of these arrows have big heads and they're coming here. So there's an enormous amount of migration. And short of building a micropore filtered wall around our country, drug-resistant TB anywhere is drug-resistant TB everywhere. And we're all in this problem together. This is why people have focused so much on trying to develop better solutions in TB control in these high burden areas to prevent generation of secondary cases. What is required for prevention of drug-resistant TB? We need to resist the human urge to go and focus all of our attention on the patients with the most highly drug-resistant forms of the disease. We need to do what we can there, but we cannot forget that the major thing that's going to improve the global TB situation is the application of the things that we know work. better dots, better supervision, trying to achieve better cure rates in high burden areas and prevent generating MDR cases, okay? This, over the intermediate and longer term, is going to be a more effective response to this. We need to cure patients when we can do this. We need to expand our laboratory infrastructure a lot because in high burden countries, we just don't have the ability to diagnose drug-resistant TB early on and quantify the problem. Drug-resistant TB is a highly lethal disease I've shown you in HIV co-infected individuals. And HIV and TB control programs in the world have mostly been vertical programs. There's the HIV clinic here and there's the TB clinic here. And trying to get both diseases treated adequately is a difficult order, but it's going to be necessary to impact on the problem. And we need to do what we can to improve simple infection control practices, cough discipline, cohorting patients, putting the patients who have previous TB treatment in the other ward compared to the patients who are newly diagnosed and have never seen treatment. Simple things that in fact can be done, but aren't done with any regularity. WHO has implemented a response document that sums up a lot of the things that I've been talking about today. Cost for 2007, 2008, $2.2 billion US, seriously underfunded, but that's not a large amount of money. It's what we spend for about a day and a half or 2 days for the current military campaign in Iraq. And just use that for comparison to say that I think there are resources just to help with the problem. And lastly, drug-resistant TB is present in most part of the world, including the United States. It's often due to poor TB treatment and TB control. Drug-resistant strains of TB should be considered to be as transmissible and as likely to progress to active disease as drug-susceptible TB. Nosocomial transmission has been well documented. Drug-resistant TB is very difficult to treat, and some cases of XDR-TB are rapidly fatal, and we are essentially untreatable. Expansion of the MDR-XDR problem may seriously jeopardize our global TB control efforts, and a coordinated response and some additional resources are needed to address this problem now before it gets larger and continues to spread. For those of you who want more information, the CDC, through their cdc.gov, has an XDR website, and they update that regularly. They're linked, or you can go to the WHO's website as well. Thank you for your time and attention. Be happy to answer any questions. Yes, ma'am.
A couple years ago, I was at a conference in Toronto where a group there was working on dipstick technology to identify TB. Is that something that you are aware of?
Yes. There are small fragments of MTB that you can detect in the urine of patients with active tuberculosis. There is some layover between people who are latently infected, and it's a technology that hasn't really been worked out, but that's really what they're up to, is trying to find a urine dipstick test that can detect these small DNA fragments in people with active tuberculosis. There are a lot of interesting things going on in TB diagnostics. We can do rifampicin resistance with a bacteriophage or other models now in a couple hours, and people said that would be impossible 10 years ago. So just with seed funding, there are actually a lot of really exciting things going on in TB diagnostics that are, moving ahead. Some of them are commercial. The competition and everything has been good. Yes, sir.
How infectious was that patient on the plane for 7 hours? Did anybody else convert?
I tried to find that out specifically. I couldn't find anybody who was willing to put a quantitative figure on it. He was smear negative, okay, and had been repeatedly smear negative before he went. And right now, it was a long flight. Because casual contact, brief contact, doesn't usually permit infection, the WHO and CDC, commercial air flight under 3 hours, probably not a problem. Longer than 3 hours, probably should be skin tested, followed up. So we don't know. But I wouldn't have liked to be sitting next to him for 7 hours. Okay.
And the right thing to do is to put a mask on, right?
Put a mask on him, the patient.
Right.
Yeah. Yeah. Or in that situation, I think you could justify, he should have stayed home. Yes, sir.
I have several questions. Number one, I was intrigued by the high incidence, relatively high incidence of tuberculosis in Japan on your slide showing the TB and global incidence. I would have expected that Japan would have been closer to the U.S. Can you explain that, why Japan has a relatively higher rate?
Japan is one of the most densely populated in terms of urban population density in the world. After World War II, a lot of malnutrition. Attack rates were extremely high between 1945 and the early 70s in Japan, and still remain relatively high. It was so bad in Japan after World War II that the U.S. State Department actually launched an initiative that still exists. We still have a U.S.-Japan TB conference every other year in the United States because the problem was that severe, and we tried to get together on the problem. In Japan, patients are hospitalized very frequently when they have TB. They get put in large hospitals. They may stay there for a year, 2 years. People abscond from hospitals. They get partly treated. It's a big problem in Japan still. Things are a little worse in Korea, where a lot of people get started out on TB treatment in the private sector by their local doctor. They may or may not get a reasonable initial regimen. They run out of money. They stop treatment for a while. They get sick again. Then they go to the National TB Program clinic. They come in and they have drug-resistant TB from the start. So all of those factors kind of feed into that. In the Philippines in the 50s, there used to be cough syrups that contained isoniazid on the market. Okay, so if you had cough, you could just go take some cough syrup and get isoniazid and develop isoniazid-resistant TB when somebody finally figured out what was wrong with you. The same thing's similar. The fluoroquinolones are used for bronchitis and community-acquired pneumonia. So there are some areas, like parts of the Philippines now, where there's actually a fair amount of fluoroquinolone resistance. It only takes about 2 weeks. So if a patient comes in and has a cough for 2 weeks, and pharmacist or doctor just puts him on an oral fluoroquinolone, and he doesn't get better, and a month later he has a smear, there's a very good chance that that patient's already resistant to fluoroquinolone.
Next question has to do with surgery for cavitary tuberculosis. Where do we stand on that now? Because that before we had the drug therapy.
Yeah. Surgical excision therapy is used in very limited cases when you have disease that's not widespread, and it's generally used when you actually have enough drugs and you can get the patient smear and culture negative and then resect the remaining burden of disease, do a lobectomy. It's very difficult. Right now in the United States, if I had to refer a patient to have this kind of surgery, and you can imagine that lung's adhesed up there, it's destroyed. There's one surgeon in Denver who's, in his mid-60s now, who I would refer a patient to if he needed resection, and so it's, there are just not a lot of chest surgeons around anymore who are, trained and willing to do this kind of very difficult thoracic surgery. And it's only helpful in patients who've got very local forms of disease or residual cavity and everything else gets better and where you still have some drug options.
Thoracoplasty, plombage would not have any effect, you think?
For individual cases, thoracoplasty being done, the problem is there just aren't very many chest surgeons around who know how to do a thoracoplasty anymore. Where it was in the old days, that's what they'd spend 90% of their time doing. We just don't have the expertise left.
The last question I want to ask is about masks. You suggested the fellow who had the TB wear a mask. Incidentally, did you hear about those cases in Texas last month where the bus driver who had tuberculosis and allegedly infected 6 students on a bus trip? Did you hear about that case?
Yeah, I think there was a lawsuit or some damages awarded in that situation. I don't know all the particulars, but it would be pretty hard to establish definitively that they were infected by that unless they developed active TB and you got a strain out and you could do fingerprinting.
I see.
But you may be able to convince lay people on a jury about that situation.
Well, that really wasn't my question. My question was, how much protection do you think wearing a mask in a crowded situation like on a full airplane for a 7-8 hour flight, how much would that offer the non-infected person? How much protection would it offer the non-infected person?
If you wore an N95, dust fume mist mask, OSHA certified yourself, the chances that would substantially protect you from infection. It's just, if you've ever worn one of those, it's a lot to breathe through. People who are elderly, and it's hard to work in them, and they're just terribly not well tolerated when you're in sub-Saharan Africa. I think the point about the mask to stress is that in the hospital per se, where people used to use just the simple surgical gauze masks and that, those, there's air in and out and everything. If you want to use that type of mask, put it on the patient. So at least when he coughs, has a moist cough, that, the big particles end up there. But for hospital personnel, we should mask the patient with simple masks when they're out. Use the N95 personal protective respirators. But the key thing in a hospital setting is early diagnosis of TB. The patients who transmit in the U.S. who've been more problematic are people, they come into the hospital, they have an ill-defined infiltrate, they've been coughing, nobody thinks about TB, and they sit there and there's another person in the room on infliximab. And, in the U.S., our hospitals are pretty well sealed up. We have to heat them. There's a lot of shared air in that U.S. hospital. One of the things that's protected in some African hospitals, a lot of them are built on hillsides. They have half-wall construction, large open windows. So in Kenya and Uganda, we have that type of ventilation, and I think that helps, and a lot of sunlight, which is highly mycobactericidal. You go down to Cape Town where it gets, it's south, it gets cold at night, people have to close all the windows. Or you go to a Russian prison where, you have to close all the windows, and you get people in there with active TB, coughing. Some of them have MDR-TB. You have an ideal incubator to transmit.
Dr. Johnson, we only have time for one more question.
Okay?
So, in an immunocompetent household contact with someone with drug-resistant TB, besides these questionable recommendations for prophylaxis, how about monitoring in terms of periodic PPD testing or chest X-rays? What do you do with the contact?
The important thing is to educate them, screen them for TB infection, document their initial tuberculous and skin test status, and then just instructing people what the signs and symptoms are of tuberculosis, and then periodically monitoring them, I think is really what we have to offer right now. Yeah. Or the quantiferon test. Both are recommended now. It's just the quantiferon is just kind of rolling out. In town here, University Hospital is not doing it yet, but Cleveland Clinic just added it as an in-house lab. So I think it's spreading to that test is becoming more widely available. It's a blood test. It's a single drop blood test. Okay.
Thank you, Dr.
All right.